Hi, this is Lee Tucker. I'm a pathologist specializing in breast cancer, and I have a strong interest, career interest, in the development of quality management programs and leadership programs for breast centers. One of the attributes of a breast center that is of greatest interest to me, and I believe is of greatest importance, is the development of a robust quality management program. We're often asked, what is quality care in breast care today? We once thought it was a simple definition, but we know now that quality care is not only evidence-based, but it's timely, it's delivered by competent practitioners in a culturally sensitive and compassionate way. And how do we keep track of all of these attributes in our breast center so that we can show ourselves, our professional colleagues, patients, the lay public, and our leadership team that we have a quality breast program? Well, the first thing we must do is create a team focus, a cultural focus on quality within our breast program. What I'd like to describe for you now is how to build such a program using the NQMBC program as its core. To do so, we have to build a specialized quality team. Most programs are too busy with the day-to-day operational and clinical issues to do a good job or a great job on quality management. And so a team needs to be assembled with a quality focus. And for this, I typically involved the breast center medical director and the operations director. But it's important not to overlook nurse navigation as a participant and the cancer registry. So if you have a talented and agreeable tumor registrar that can join the group, that's wonderful. And then add to it an IT specialist for just a fractional portion of his or her time to lend to the process. Round out the team with a few of the basic clinical specialties such as surgery, radiology, pathology, and oncology, and you're good to go. It always helps to start by identifying the areas that management is concerned with. Sometimes you have operational issues, bottlenecks in waiting rooms or in report delivery that management would emphasize as perhaps a more traditional means of assessing quality. But these have to be taken in the context of clinical concerns as well, those that might be raised not only by your core group of practitioners, but by other physicians in the practice community, whether they are in alignment necessarily with your breast program or not. Once you've identified these, then it's reasonable to consider ways of monitoring your performance in those areas. But before I get to that, it's also important to be mindful of the organization's priorities for accreditation and certification. And one thing is certain, we have more opportunities than ever today for accreditation and certification, and the requirements of collecting and reporting the data for these certifications creates a resource burden on the facility. Some organizations are set up to do this in a very facile manner, and others have to struggle with the development of data and reporting because they're not particularly well interfaced across the electronic health record, or they have manual charts that require data retrieval. So the accreditation and certification opportunities often have to be prioritized. You need to begin with a set of core measures. And core measures are those measures that you feel are the most important to your program on an ongoing basis. And again, these might be because of areas that were identified by management or clinical concerns, or are measures that come from a well-reasoned data set such as the NQMBC. The NQMBC has a list of about 37 measures altogether that can be broken down into several categories. Some of these relate to the service level of the care delivery, such as 7 measures concerned with timeliness of care and 5 that are involved with patient satisfaction. Others relate to professional performance, such as the 7 measures of pathology report completeness, or 3 measures of breast conservation surgery. There are an additional 3 measures for chemotherapy, radiation therapy, surgery, and imaging, along with 2 measures for adjuvant endocrine therapy, and finally, 1 measure of clinical outcomes in the 5-year survival rate. There may be other data required for accreditation depending on what the accrediting body requires. So it may be reasonable to roll those data requirements up into your total data requirement for your quality management plan. Now, having done this, you'll find that the NQMBC allows for a segregation of programs based on their size and complexity, based on the types of services that you develop, so that programs that are primarily involved with screening of patients are only required to submit a couple of measures, whereas those comprehensive breast programs that involve screening, diagnostics, adjuvant therapies, reconstructive surgery, and research have a greater requirement for data submission. So the NQMBC is scalable depending on the size and the complexity of your breast program. When reporting your data, I find it useful to have the program leadership group as a whole set forth clear expectations for what data will be reported to the Quality Management Committee and to the advisory board or program leadership, and on what basis. Sometimes a quarterly report is adequate for some data points, an annual report might be adequate for others. Remember that the reports that go to management should be inclusive of all the information that is gathered, but that the management team often has a slightly different perspective, and they're interested in benchmarks. And I raise this because the NQMBC program does not create benchmarks per se of what quality care is. Quality care is a relative term that may reflect your longitudinal performance or your performance over time. And the program allows you to compare your existing performance with historical data submission. But it also is relative to what other programs are able to submit. And so where you define quality and where you define a benchmark to be might depend on whether you want to be in the 90th percentile, the 70th percentile, or the 50th percentile and above. And remember, the NQMBC is a voluntary program, so we're already looking at programs that perhaps have a better than average emphasis on quality by virtue of their data collection and reporting methodology that is in place. So if you're in the 50th percentile, don't feel bad necessarily because you're in an elite group of breast programs. I would say that it is important to report regularly to program leadership on a predictable and reliable level. So whether it's an annual report, quarterly, or even a monthly report, pick the frequency that is suitable to the program leadership and have your quality subgroup report on that basis, and in turn report to the organizational leadership, to senior management on a regular basis as well. Use the NQMBC program to compare yourself with other programs and to your own long-term performance. Use outcome data to establish your program priorities and for strategic planning purposes. For instance, if you want to engage in an expansion of your program or a new clinical offering, the data can be used to guide and shape the nature of and the urgency of that program expansion. And then don't forget to tell your story. Report your program's performance externally, not just to the obvious sources such as the certification or accreditation programs that you have in mind, but to the lay public, to the community. It's very important for the public to know that you're interested in quality, that you're following your own quality, and that, in fact, you reach them on so many levels in terms of being evidence-based, timely, culturally sensitive, competent, and, of course, compassionate.